As Daniela mentioned, I am a professor of electrical engineering and computer science at MIT and a cardiologist at the Massachusetts General Hospital. And I wanted to, with my clinical hat, pose a provocative question. Actually, not even a question, it's a statement. Doctors don't treat patients, rather, they treat averages. Now, the next slide I put to remind myself to not forget the dramatic pause. Just to let that concept sit in. So, but I don't want you to walk away from this saying this guy came across, made this very polemical statement and left us with no idea of what it meant. So let's unpack this a little bit. Doctors don't treat patients, they treat averages. What does that mean? Well, if we're going to understand it, we have to sort of take a look at how treatment decisions are made. When you go to see your healthcare provider, they have a corpus of data available to them based on clinical trials, expert recommendations, but it's really clinical decision-making is guided by the results of clinical investigation, clinical trials in particular. And clinical trials come in different flavors. There are preclinical studies, that's the stuff that happens in vitro, animal studies, not that relevant to humans, and eventually goes all the way up to post-market surveillance. Phase 3 trials, I think, are the big ones. Those are the ones that are published in the New England Journal of Medicine. You'll see the title in CNN or other sort of websites that you might peruse. They're randomized controlled clinical trials. Now, if you want to talk about that trial in particular, because that's the one that is often the most dispositive in clinical decision-making. So that's where you take a bunch of people, you put them in a control group, you take a bunch of people and you put them in the non-control group, the study arm. You're going to do something with people in the study arm. You're going to test a drug, you give the drug to people in the study arm, you give something else to people in the control arm. You do some stuff, you watch them, and you look at the average result between the two groups. Yeah? So when I say that physicians treat averages, that I mean that treatment protocols are based on average responses. Physicians strive to treat the average patient. Yeah? Now, the individual response rate, the individual clinical trajectories can vary a lot. And it's even worse because the averages are over very specific populations. Because randomized control trials, those people in the control group and those people in the study arm have to fulfill particular criteria. So just to make the point, just to drive it home, I'm going to take a look at some real data. So if you look at some trials of antihypertensive medications, people with high blood pressure, and you want to give them a medication and see if it lowers their blood pressure, it's randomized control trials, a study arm, a control arm. And here I'm looking at the exclusion criteria for 5 different trials. So if I look at the first trial, exclusion criteria, use of weight loss medications. Well, I'm trying to think in my clinical practice, how many people have I seen that are on weight loss medications, especially in 2026? Lots of people have been excluded there. Congestive heart failure. How many patients have I seen? I'm a cardiologist that have congestive heart failure. They wouldn't have been in that trial. Okay, how about if I go to the third one? Wing it out. Any life-threatening illness. How many patients have I seen that I would categorize as having a life-threatening illness? Yeah? If you actually look at the data in terms of the trials themselves and the eligible patients and the patients that were enrolled, in many instances, about 1/3 of the potential patients that were screened were actually enrolled. Most patients in the real world would not have been enrolled in any of these trials. So we have the following proposition. The clinical trial data, or the insights that arise from this, are quite different than the patients that you see in clinical practice. And moreover, most patients that are seen in clinical practice, it certainly holds true of me and my colleagues, would never have been enrolled in any of these trials. So clinicians have to extrapolate. So I see a patient, I say, well, you wouldn't have fit into this trial. But you're kind of on the edge, you have similar characteristics, and I'm going to use these clinical insights to dictate my reasoning. Yeah? Far from ideal, far from ideal. So let's dream for a minute. Let's say if we could do a clinical trial with one person. Let's say you could make a copy of yourself and you could do experiments on yourself. You had an exact copy, and I don't just mean genetically, I mean exact in every way. We're going to dream, right? Now, ethically, it's a questionable proposition, but it's certainly not possible. But what can we do? Can we create copies of ourselves in the computer? Can I create a copy of myself that would have the same health trajectory, the same health history that I had, and I could use that to predict my future health trajectory? Then I could do experiments. Yeah, I could, in my computer copy, I could give them drugs that I think might be apropos and see my response, see if I do respond or otherwise. And this is the whole concept of digital twins in healthcare. It has been fodder for the development of a number of companies, a lot of scholarship, some good, some not so good, and a lot of work both going on in healthcare setting as well as in computer science departments. The potential benefits are pretty large, as I've already alluded to. Predictive analytics, you could predict the future, accelerated assurance and research to the patient. If you take this, a patient can follow their own trajectory, know that maybe they'd have a lower risk of heart disease or cancer and so forth. Operational efficiency, I can know exactly where to invest my resources because I can have predict future trajectories for different cohorts. And personalized treatment, I don't have to do this averaging business anymore, right? I could take a patient in the computer, it is a copy of that patient, has that own patient's nuances, their specific medical history, and I could follow their own trajectory. So what's a way, how is this operationalized? How would this work in practice? So again, we're still in our fantasy world, yeah? We have a patient, we have a healthcare provider, and then this healthcare provider makes 3 copies of that patient and have 3 potential drugs that they think might be helpful. They can give 1 drug to each patient and map out their future trajectory. So the patient on top has a lot of interventions and gets admitted to the hospital. A patient that takes drug number 3 has a similar course, and the patient who takes drug number 2 actually has a good outcome. So you could do these experiments. Now, this sounds pretty fantastic, right? How could you do this? But how many people have used ChatGPT today? In the last week? In the last month? Oh, this is an odd audience. Usually when I ask that question, everybody puts up their hand for the last month. But certainly it's the majority of individuals here. A lot of this machinery already exists because that's actually a lot of what these generative pre-trained transformers do. They give you a trajectory of words, and they're trained in a manner so that you can give them the initial part of a sentence, and they'll finish that sentence for you. So let's say, could we apply this technology to patient data? Could I give the same algorithm a segment of a patient's medical history and see if it could predict the future? So the machinery is there, yeah? So let's say that we try to apply this directly in the same manner that ChatGPT was trained. So I'm just showing the ChatGPT training formalism. It's not that meaningful here, but I just want to focus on the first part. You've got a massive unlabeled data set. Yeah? So if you scrape all of the web available books to look at all of the sentences and the words, you've got a lot of information, billions and billions, tens of billions, hundreds of billions. How many people are on the planet? 8 billion, depends on how you do the math, right? 8 billion, 9 billion or so. So there's no way that we could get enough clinical data, right, to be able to be on par with what ChatGPT does, yeah? So let's say, this is where the fault lies. Your initial thing that you would do is you'd amass as many patients as you can, you get their clinical trajectories, you put them into the same machinery, and you try to train a model. Limited by the number of data, because the data sets are not going to be as large as what you get with respect to training ChatGPT. I'll just be 2 minutes more. Moreover, the large clinical data sets are heterogeneous in ways that we do not understand. 2 patients can have the same diagnosis of breast cancer. You can treat them the same, but they have very different outcomes. We have breast cancer as a name of a disease, but it's likely many, many different subtypes. And similar statements apply to at least all of the diseases that I am aware of. So there's heterogeneity there that makes it more challenging. So what you'd like to do is to be able to take this cohort, find the similarities, And the similarities are subtle. We're going to learn something about this clustering procedure and make a model that's specific for each of these subtypes. Now, so when as you saw from the first slide, I've got a number of jobs, a number of bosses, and I think in some contract I signed somewhere, I have to either put an equation on a slide every talk that I give, or something that alludes to some mathematical representation. So here it is. So we've done this work, we've built these sort of models with the specific purpose of identifying these patient phenotypes. And we have some results that show you can do this effectively, cluster patients in ways that are completely non-obvious, that group them into different, those that are high risk and low risk. And we've worked on building predictive models, which are not simply implementations of the existing transformers, because the tasks are a little bit more challenging and demonstrated increased performance above existing models. So I'm going to end with the following. So because the title of this exposition was Promise, Peril, and Path Forward, and it sounds like I'm saying a lot of promise. So let's have a reality check. So the promise here, these digital twins, do have the potential to realize patient-specific personalized care. Much of the technical machinery here already exists. Peril, would you trust your digital twin? Well, if you're training it on these subgroups and your particular subgroup is quite small, the model may not be robust. And I think as important, if not more important, the potential for bias is significant. Path forward, I think the future is bright, but these models will need prospective evaluation to build trust, so stay tuned. I will say in my closing comments with respect to this work, I'm going to try my best not to get on my soapbox, but it is my view that everybody has the right to exceptional medical care, no matter what you look like, where you were born, or what your zip code is. Moreover, everyone has a right to mass general level of care, whether you're in Brookline or whether you're living miles away from the nearest healthcare provider. And the work in this end and in my group is towards that end. And I always show the people who do the work at the end of my talks. Thank you.